Well, thank you very much, Pierre. I'm really grateful to the people who asked for that primer on health economics, because from what I've heard yesterday and today, some of these considerations are quite far from your everyday preoccupations and concerns. So basically what I'll be trying to do is give you an overview of what it is, and not only as healthcare professionals, but also just as citizens, as you may be interested to understand why drug prices are so high and what policymakers make this with the studies. And also, for those of you who are in clinical work, it's now in every specialty journal, not only liver journal, but throughout all medical specialties, you see health economics papers. And again, for those of you who do clinical work, you will have the pharma representatives presenting you with such articles and discussing the results, which necessarily will be very much in the favor of the product tested, so that you should be able to critically appraise the results. So this is the outline. I will start with some misconceptions about health economics, because this is what most people, and not only healthcare professionals, but the general public, think about what is health economics. So we'll start with what it is not. So it's not costs alone. It's not a cost calculation. It's not about reducing healthcare expenditures, because that would mean, I would not even dare show my face here, because for the past 40 years, healthcare expenditures have increased. So it really would mean a spectacular failure. It's not about killing patients. And again, this is something that I've often heard from my colleagues earlier, is that if people die, then you have no costs, so it's all the better. It's not quite that. And we did see that when people are sick or when there is a lockdown, the economy also suffers. So we're not out there to kill people. And so basically, what are we here about? We're here about to find what you need to pay to get health gains. And the fact that we say health economics shows that the first word is health. The first part of the expression is health. And so we really are talking about health and about what it means to gain health when you have to pay for it. So we are talking about the relationship between a health gain and the money you have to pay in order to achieve this health gain. You, as healthcare professionals, it's a complete household discussion topic now. You've heard about the 2 million per treatment gene therapy. You've heard about the 350,000 per treatment CAR-Ts. So everyone talks about that. Our health expenditures increase, and then yet patients, I'm sure in your surroundings, think that their care is not properly reimbursed, that they don't get access to the care they like. More in the US than in Europe, but you have lots of papers about something called financial toxicities. And so you knew about drug toxicities and side effects, but now the Americans talk a lot about financial toxicities. And there are even questionnaires to assess financial toxicities alongside various treatments for cancer, for example. So it is a topic that is gaining interest. This is to show you that it has really become a household topic. This was an ad campaign, the French among you, the Parisians, because I think it was mostly in Paris, might remember it. It was in the bus stops. There were billboards explaining, well, the pharma industry made too much money out of diseases. And so I've translated some of those. The billboards were withdrawn after a formal complaint. So again, everybody knows about it. This is another example about liver drugs, hepatitis C drugs, that it is in the public, on websites, certainly in medical journals, but also in newspapers. And here you have something interesting, which is that nobody does quite agree about how do you decide on the price of a drug. And you will hear, so there are lots of economic theories out there. And so you will see that people pick one or the other, depending on what they want to show. So sometimes to justify the high price of a drug, you will have people discussing the R&D costs. Okay. So now, prices based upon costs is what planned economy in communist countries was, by definition. When you decide the price based on production costs, it's planned economy in communist countries. And so it's quite strange to hear some of the rather large capitalist manufacturers claim that. Now, another thing you hear is price should be based upon value. So this is typical market economy, and it's completely consistent with our liberal system, a market-based system. But again, it's not what happens, because I think aspirin has a lot of value, but yet it's not very expensive. And then you have something here, which is also interesting. It's an economic theory, which is called discriminating monopoly. And you know it very well, because it's the fact that monopolies can charge customers depending on their ability to pay. And this is the discounts you have or have not on airline tickets, train tickets. And this is what this pharma company said. We are going to have a different price depending on the country's GDP, gross domestic product. And this is exactly what is happening. And this is also why the Americans tend to pay healthcare far higher drugs, much higher than European countries, and possibly much higher than low middle income countries. But so you see, at some point in time, you should decide which is the economic model you want to base your pricing upon. And this is not happening. So depending on what you want to get, you will choose any model you like. So this is, for example, the relationship between the price of a drug and the GDP. So you see that most countries are on a kind of a slope, which is the middle of the plane. But you see that there are some people who are very unfortunate. So Poland seems to have the bitter taste of very high prices with very low income. And the US are kind also of outsiders, but much less so than Poland. So now, what are we talking about? Again, we're talking about trying to find out how much you have to pay for health gain. So there is no economic evaluation if there is no health gain, unless you're doing a non-inferiority study, which I'll be discussing later. So normally you assume there will be health gain, and you just ask yourself, how much do I have to pay for this health gain? If you do a non-inferiority study, what you expect is either better safety, because all of you know that non-inferiority is a misnomer. It's inferior, but it's acceptably inferior. So you have some inferiority of efficacy in exchange for better safety or lower cost. And this is why now we're doing quite a lot of studies based upon non-inferiority trials. So it is, in effect, not at all different from what you do every day in your life when you decide to buy something. And this is what you have to understand, so that you don't think health economics is something so esoteric or strange. When you buy something, you decide how much, because we have a choice in capitalist countries, you decide whether you want to pay more for something better. So you decide if you want the look Timothée Chalamet with the Louis Vuitton hoodie and Swarovski crystal, it's going to cost you about 50,000 euro more than this, okay? So depending on who you are and what you're aiming for in life and how much money you have, you're going to decide which kind of clothes you like. And when you do that, it's very easy for you, and you do it every day, not necessarily for hoodies, but for coffee, meals, leisure, cinema, whatever. It's very easy for you because you perfectly know how much money you have to spend and what you like. And so you're the person who makes a decision, pays, and consumes. And your goal in life as a rational person is to maximize the satisfaction you get from your money under budget constraints. So you have a budget and you decide to spend this budget or to save it, either to buy things or to donate. So it's not necessarily at all a selfish behavior. You can decide you get a lot of satisfaction from donating money to a charity or an ONG, or from buying Swarovski studded hoodies, or from saving money. But you decide it based upon your satisfaction, the satisfaction that you will derive. And remember that word satisfaction is a lay word for what economists call utility. So utility in economy has a slightly different meaning from the usual meaning. So in real life, it's fairly easy to do. For health, of course, you have another problem, which is that the person who pays, the person who decides, and the person who consumes are three different persons, and that you do not have an immediate price tag on health interventions. So what we need to do is to recreate a market, sort of, with prices and value. And you, again, you have as an individual, you have in your head your ranking of values for everything you consume in life. But that doesn't exist in health. So what we have to do is to make it up so that the people who spend the money know what to buy and know how much they should pay for a given amount of health. But here you see that the two variables, how much does it cost and how much health do I get, are not available. When you go to a shop, you have a price tag, and you know whether you like nice sandwiches, nice coffee or not, and how much you are ready to pay for a better sandwich or a better coffee or better clothes. That does not exist in health, and this is what we have to recreate. And that is what health economics does. So when I told you that the amount of money you spend on consuming goods or donating money or saving money is directly related to the satisfaction you have, basically I'm telling you that you have a unifying metric for everything you do in life, for your satisfaction. And you can compare satisfaction from very, very different uses of money. You know if you prefer to spend your money on cinema, on restaurants, on donations, on clothes. They are very different goods, but you can just rank them in your head because you have that metric, which is how happy will I be with that type of consumption. So you can compare shoes and wine, which are really quite different uses. But in health, we don't have that thing that compares directly all medical specialties. So you, in liver treatments, you probably have life-saving interventions. So do cardiologists, and so do oncologists. So you could use life expectancy as a tool. And this is what happens commonly in liver disease models. But think of ophthalmologists. Think of rheumatologists. They also provide health, create health, but they cannot measure what they create with the same metric as you do because they don't save lives. And so what was needed is to create, and this is what has been done, create a metric which was exactly similar to this idea, this concept of satisfaction or utility that you have in your head and that allows you to rank wine and shoes and cinema and opera and holidays. So the economists created that metric, which you know of. It's the QALY. You've read that acronym. And that metric is just there to reproduce utility or satisfaction that you have in your head, and that allows you to take enlightened consumers' decisions. So to measure health, we use QALYs because they can compare every medical specialty with one another. There's a very strong assumption at the basis of QALYs, and I'll show you how they're calculated, which is that quality equals quantity. That it is the same for a person, for a patient, to gain in quality of life or in quantity of life. And you see it's pretty strong. But then when you have made that assumption, you can multiply one by another. And so it is equivalent to gain health through increased life expectancy or through increased quality of life. It's considered to be the same. And this is what we are doing. And this is why yesterday we discussed the EQ5D questionnaire for the combat trial. So this is how you calculate QALY. And this is just a simple illustration of the fact that they are the same. The surface can be increased either by increasing the quality or by increasing the quantity, and the result will be the same. And you can increase your QALYs either by increasing quality of life, quantity of life, or both, which is what is shown in here. So how do we do it? This is the EQ5D. It's a questionnaire which is generic, European, translated in as many languages as you want. And so patients fill out it's called 5V because 5 domains. This is the 5L with 5 levels. And so you tick a box. And so in the end, you describe your quality of life today with a string of figures, 5. So if everything is well except the last two, for example, you say, no problem in mobility, self-care, usual activities, a bit of pain, a bit of anxiety. So you're 1, 1, 1 to 2. So how do you go from there to QALYs? You take a table. It's called a value set, and it exists for most countries. You look, so we have it in a program. You don't have to look through every combination. So you look at what you are today, and then you have the value, which is a coefficient between 0 and 1. And that you will use to multiply by the life expectancy, or the interval between 2 visits in a trial. And that will give you the QALYs. And then you will add up everything. So it's like Kaplan-Meier curve, except reverse. So here you have the utility levels, the intervals between visits in a trial, and you just calculate the area under the curves to get the difference in QALYs between the two groups. So this is how we measure health. And there are many limitations to that approach. As you see, the questionnaire is pretty crude and certainly does not allow you for disease-specific measures. But that is why we can always combine it in clinical trials with a disease-specific instrument. But this is, I believe it's here to stay, because it's very simple. Everybody uses it, and then it allows this calculation across medical specialties. So now costs. There are 3 words which are not synonyms, cost, price, and tariff. And also the notion of value is something different. So when we say cost in an economic evaluation, we mean usually production costs. But these are sometimes not available. So we will use price. So for a drug, it's the list price. And tariff, it's like, for example, for a consultation, we will use a tariff is what the payer pays to the professional. So tariff is how much the social health insurance or the National Health Service pays for a consultation to a doctor. because we have no production costs. So this is what we will use. As I said, there are endless discussion about fair pricing for drugs. And what is interesting is that the attitude of how you determine the price varies between countries. The good news is that there are roughly only two ways to do it. One is the variable of adjustment will be a reimbursement. So for a given price, the payer decides, I reimburse, I do not reimburse. And there are other countries, and these tend to be more the Bismarckian countries, where the variable for adjustment is the price negotiation. So you first decide on reimbursement. This drug has value to the population, so it will be covered. And now we negotiate on price. And then you try to have as low a price as possible, given the expectations of the manufacturer. And so here I just summed up what we discussed earlier about what models are used for drug pricing. But we always use in a clinical trial the academic definition. We take the resources that are committed to obtain health gains, and we try to value them. That means, for example, in a hospital, we would take salaries, wages, if these are available. So now, how do we categorize costs? This also explains to you some of the vocabulary you will read in specialty articles. They are separated usually between direct, indirect, and medical, non-medical. The direct costs, which are on the first line here, are those that are necessary to treat a patient, to obtain the health results. So what is funny is that the division between what is medical and what is non-medical has changed a lot over time. So for example, in France, homeopathy used to be medical, and now it's delisted, so it's non-medical. Sports therapy used to be clearly non-medical, but now it can be prescribed, so it's become medical. Same thing with psychology. It used to be non-medical, but now it can be prescribed and reimbursed, so it moved to medical. So don't get too strict on what we mean by medical and non-medical, because it's likely to change over time. Now the line below, indirect, is the consequences of an illness. So here again, you've heard that they're called production costs. So should we include in the cost calculations the fact that when you don't work, there are production losses to your country? So we thought it was a bit futile, but then again after COVID, when at least France lost 8 points of GDP, so we know that it's not completely ridiculous. And then the last box, which is the medical indirect cost, is something that's highly debated. So say you have a patient whom you save from cirrhosis by either treatment or doing liver transplant, and then this patient has a lung cancer during his survival. And so should we take into account the cost of treating lung cancer or not? So the answer so far is no. What we take into account is everything related to the same system. So if it's the heart, we go for all the vessels, the heart and everything. If it's the liver, we go for everything that surrounds vaguely the liver and the liver itself, but not for lung cancer, for example, or for colonic cancer. So this is roughly how we do it. And in economic evaluations, we measure costs and we measure health. Now, what is important to understand for the calculations is that the two are not independent variables, and that they are highly correlated. So, for example, if you put a stent somewhere, there is a one-off cost. You put the stent, and then the more efficacious it is, the less costly the follow-up will be. So in that case, and it is very usual in device interventions or surgery or gene therapy or possibly CAR-Ts, you have an initial sort of investment, and then if it works, you expect the costs during the follow-up to be declining. So you would have a negative correlation between cost and effectiveness. Now you understand very well that it is exactly the opposite relationship for cancer drugs. When you have drugs that you treat to progression, then it's exactly the opposite. The more efficacious, the more costly. So in that case, the relationship is positive, which means that you must not assume that the two are independent, and you must not assume that you can use the costs in one country to calculate, to do the economic evaluation in one other country. And this is why we are sometimes a bit worried when there are international trials, and when in these international trials there are countries with a federal system where the costs are different in each province. That's an interesting twist. So there is guidance on economic evaluation, and these are completely publicly available and can be looked at anytime. So what we do is, for an economic evaluation, it's usually trial-based, and so we just follow the patient and just collect everything that is happening to the patient during the clinical trial and estimate the difference in health measured with AQ5D and the difference in costs. And so in the end, the presentation of the results look like this, and you've seen that, I'm sure, already. Horizontal axis is the difference in health. So here it's exactly what you know. It's like when you represent health gains in a forest plot for a clinical trial. You just here on the right, the new treatment is better. On the left, the new treatment is worse. But then it's exactly like any forest plot you've seen. You just position the health gain on the horizontal axis. The new thing with an economic evaluation is that you have the vertical axis, but same idea. You will position the difference in cost. Either it is positive, so you go up, or it's negative and you go down. So you have 4 possibilities, too easy, too difficult. If we start with the easiest one, which is the top left, this never happens for drugs unless the manufacturer has made a big mistake, because in that case, the drug should never be out. Normally, if a drug the strategy with a new drug is more costly and less effective, it should never see light. The other possibility, which is the easy one, is the bottom right. So when you have a new treatment, a new strategy, which is both cheaper and more effective. So that's really nice. Now, the more frequent situation in medicine as in life is the upper right. It's better, you gain health, but you have to pay for it. And then the bottom left is the non-inferiority studies, typically there. So you have in theory, a small and acceptable loss in effectiveness. And what you expect is a reduction in costs, better safety. So now I've enlarged the upper right. And so this is the answer to question you sometimes, or a comment you sometimes hear when people talk about health economics and the value of life and how much should I pay, and so there are answers provided by the World Health Organization and by the National Institute of Health and Clinical Excellence, for example. If you look at this part of the plane, you see that when I plot the gain in health on the horizontal axis and the additional cost on the vertical axis, I have the coordinates of a point, and this is the point estimate for my result, economic evaluation. Now, when I draw a line from the origin to that point, the slope is exactly what I'm looking for. It is the incremental cost effectiveness ratio. So it tells me how much I need to pay for one additional year of life in good health, or 1 unit of health. So you can look at that plane, and it's extremely easy to interpret. The 2 lines I've drawn here, the dotted lines, are recommendations from the World Health Organization. They say that paying one time the country's GDP, so France would be 35,000 euro, as would most West European countries, more for Germany a bit. So if you pay between 35 and 40,000 euros for 1 unit of health, so 1 year in good health, it's completely acceptable. Now, so that's the lower slope. Now, if you pay 3 to 5 times that amount, so 150,000 euro for 1 additional year of life for 1 person, always standardized to 1, then it begins to be a bit expensive. You're kind of living above your means, which is what we all are doing, and we're accruing debt, which will be paid by the next generations. But so that's what WHO says. In the UK, the National Institute of Health and Clinical Excellence has a threshold which is 40,000 pounds per QALY, but it's very difficult to uphold. So now, and this is an explicit threshold. France and Germany and Austria do not have explicit thresholds. And it's kind of more comfortable, less transparent. So it's really a political decision. If you have an explicit threshold, it's really transparent, but you run the risk of having every person in the Department of Clinical Research in the pharma companies just plot X, the price of the drug, and solve the equation for the maximum threshold. And so you're quite sure that every product that comes to the market will be at the maximum they can demand from the country. If you don't have a threshold, it's far less transparent. You run the risk of certain patient groups or advocates feeling that they've been misused, that others get more. But then it's kind of more comfortable for the payer, I think. It's completely a political decision. My role is absolutely not to say it's too expensive or it's not too expensive. People in academia should not do that because we're not elected. We have absolutely no legitimacy. We just say the incremental cost effectiveness ratio is 250,000 euro per QALY, and that's it. And it's then what you do with it is completely political. So this is another article, same cost effectiveness plane, but there's one funny thing about this article. It focused on the lower left. You have to give up some health in order to save money. And it's called decrementally cost effective. But it's not the funny thing. The funny thing is that this was published in 2009. And if you look at the citations in PubMed, it has been very little cited. Because in my interpretation is that no one likes to do that. No one likes to think that in order to reduce health expenditures or to save money, we're going to give up on quality. But again, as I say, it's coming now with the non-inferiority studies, dose reduction study, treatment holiday studies, whatever you want to call them. Holiday is slightly nicer than reduction, but so we are exploring this kind of lower left quadrant now. So what would it look like? This is how results are presented. So I took an example from liver disease, is hepatocellular carcinoma. So in the end, what you have is just a simple table. You look at the cost. I'm sorry, it's in French because it's from the National Health Authority. You have the cost for the 2 treatment options, so 35 and 140, 24,000. You have the amount of QALYs gained by each strategy. You have the life years. AV is life years in French. And you see that, as you expected, for each strategy, the life years are higher than the QALYs because patients do not have a full quality of life. And then you have the incremental, so that's the French for ICER, incremental cost effectiveness ratio. And what you do is that you just subtract the sorafenib cost from the Tecentriq costs and divide by the gain in either QALYs or life expectancy, and then you have the ratio. So it's just a ratio. Calculations are fairly simple once you've got the figures. So you just divide the additional cost by the gain in health. But it is exactly what you do when you're shown two scarves. This one costs 50 euro more than that one. Is the better quality because the wool is better, because it's softer, because the color is better, worth the 50 euro difference? And you decide like that. In health, it's just longer, but exactly the same principle. And so now what do we do when we don't have the data that is long enough to have meaningful results? So it's extrapolation. And this is what also we plan to do with combat, because we have a 90-day follow-up, and it would be nice to know what happens afterwards or to have an idea. And so extrapolation uses several functions, and this is what we did using the predict cohort data. We tried to fit extrapolation functions, and you see what people do is they test every function that are in the book, and see which one looks better. It's a bit problematic when you have 3 months worth of data which you're going to extrapolate over 30 years. So we try to limit the extrapolation to a reasonable number of years, but it's the same idea. And so there are lots of models that are used to extrapolate data, and what we would put for economic evaluations. Why? Not only because it's nice to know what happens after the end of the trial, but because when you have a drug, or more frequently a device or surgery that is very expensive, clearly the manufacturer wants to expand the initial cost over a longer period of time. So if you do gene therapy, 2 million, if you just look at 1 year worth of data, it will cost 2 million per life year. If you expand it over 40 years, then you kind of have a better looking incremental cost effectiveness ratio. And so this is why all this is done. So this is not the Scatterplot we saw earlier. It's the one that we use in cost effectiveness analysis, and it represents the confidence interval. As I told you, we have 2 variables which are correlated, so we cannot just do a simple box from the cost effectiveness plane. So in order to get the confidence interval, we do this. It's just resampling method. And this shows you the uncertainty. So you plot it. I mean, it's done immediately. It's very straightforward. Excel does that, R does that, SAS does that. There's nothing complicated about it. So it's plotted on the cost effectiveness plane. So the point estimate is the red dot and the green dot. So if I were to draw a line between the origin and this, I will have my ISA, the point estimate of the ISA. And this just shows you the uncertainty on the result. I like these planes very much, this Scatterplot very much, because it gives you very clearly, it shows you very clearly where the maximum uncertainty is. And quite commonly now with the new drugs, which tend to be highly expensive, there is very limited uncertainty on the cost. And so you can see that my Scatterplot is not very fat. Height-wise, it's not very tall, but it's very fat. And it's very fat because there is a lot of uncertainty on cost, on benefit, on QALYs. That, as a clinician, well, oncologist here, would make me very uncomfortable. It's far worse if you look at the CAR-Ts. I mean, all this is completely public data. If you look at the economic evaluation for the CAR-Ts, you will see that the uncertainty on the benefit ranges from 0 to 8 QALYs, 8 to 8 years. So you kind of think, oh, there's a lot of uncertainty here. It would be nice if we had more robust data to make a decision. So this is why I like it. But then, for people who do not like Scatterplots, the data can also be presented this way. It's exactly the same data, but it's, instead of being a Scatterplot, it's 2 lines. It's called acceptability curve. It allows you to decide which strategy you prefer. So here, sorafenib or Tecentriq, based upon how much you're willing to pay for a life year. So this, you just plot your threshold. So if you're, but we start here, you see that we start at 100,000. So it's a little bit like, I want to have a nice meal, but I only have €100, which is already quite a lot, but I want to, for two. I want to have a nice meal for two. I only have €100. What is the probability that I will have a good meal if I go to a 3-star restaurant? Here the probability is 0, because you will just get a coffee. Okay. Now, say I have, what is the probability that I get a good meal if I go to there's one called Pasta e Basta in Paris. So there with €100, you can expect to be reasonably well fed. So this is the idea. If you have only 50, you go to sorafenib. If you have 300,000, you can go to Tecentriq. So this is how you read it, but roughly it's the same data, just presented in a different manner. But you decide how much you're willing to pay for 1 year of life, and up you get the answer to your question, what should I do? Again, I will insist on that because I think it's quite interesting to see the differences between countries, but it's not I who should say that. It's a completely political decision. And you understand that for some groups of patients, mostly rare diseases, for example, or groups that have been neglected for a long time, then as a political person, you may be ready to pay a lot more than for, say, hypertension. Okay, so it's that. So we provide the data, and the decision is political. So this is another form of representation of uncertainty. Again, it's public data of French National Health Authority. Here you have a scatter plot. So here it all starts at, this is 100,000. And again, this is a point estimate. But you see that having the scatter plot gives you far more information than just having the red dot and drawing a line from the origin to the red dot. Because here you can see all the uncertainty. And this is another way of representing uncertainty. You just want to know which of all the parameters that influence the result, both on cost and effectiveness, on health gains, is the most influential, is the most important. And so it's called, then what you do is you have a program which varies parameters one by one. And then it ranks them nicely, so it has the shape of a tornado, which is why we call it a tornado diagram. And here you see that what matters most is the uncertainty on the conversion, on the efficacy of the drug. So other representations of uncertainty. And sometimes we don't have a trial, and so this is what Pierre-Emmanuel was alluding to. So we just do a model. So we use data from the literature, and this was a study we did with Pierre Naon on should you use MRI to monitor your liver nodules. And so the answer is it depends how ready you are to pay, but this is fine because the ISA we calculated was much below the usual threshold, it's 15,000, but this is a model, and now we're confirming it with a clinical trial. So this is what a model looks like, and this is what we will also be using to extrapolate the combat results. And so you have that, again, same thing, scatter plot, and you see that there's a lot of uncertainty, which is why we're conducting a trial. And then same acceptability curve, tornado diagram, and what matters most here, of course, is the incidence. And if you do MRI on patients who have a high incidence of cancer, it will be much cheaper than if you do it on patient groups with a 0.5% in the early incidence of cancer. So some of it is really obvious, but it's nice to have figures to show it. And then when you have the results of an economic evaluation, the big issue is the external validity. So that's when you read studies that have been performed in other countries. The checklist is really, is it interesting for me? Will it apply to my country? Do I have the money to buy the drug? Do I have the capacities to do, I don't know, CAR-T cells? So how does it work? What are the expectations of the population? How will it be? If you're substituting one treatment for another, what are the stakeholders? What are the medical specialists thinking about it? All this is also included. And this is what makes the political decision. And you have several levels, because you have the decision at the national level, and then will your hospital adopt it? And it's clear that if you're paid, like I think most of us are using prospective payment system, DRG-like system, if a new treatment shifts patients to the to consultations, if it reduces the activity of the hospital and therefore the hospital revenue, there might be problems to overcome before it's accepted. So all this has to be taken into account. So that was it. Broad overview, but just I hope you will it will be helpful for your next discussions about the value of life. Bye.